So, un placer como siempre estar aquí, pero voy a cambiar a inglés y hablaré muy despacio. So it's Mark Emberton slides. I thought I would start the talk by justifying why we should be exploring yet another mode of treatment. Is there... We've already heard about the desire for a more personalized approach to care. And I think if we look back at the last 100 years, since Hugh Hampton Young first did his radical prostatectomy, we have been using a kind of one-size-fits-all approach to patients in the sense that we are offering surgery or indeed radiotherapy irrespective of grade, volume, multiplicity, and indeed risk. And I think today, with all the technologies and techniques that we have available, we're going to be in a much better position to risk stratify our patients with great precision and then allocate treatment in a more rational manner. And it's that process that allows us to ask new questions in terms of the treatments that we can offer our patients. And we're nearly there. So I can't remember putting these slides in. Yeah, although they're very beautiful. Okay, great. So here we are. So first of all, some of the rationale. So before coming here yesterday, I was in clinic, and largely my role was to assess whether men who had been offered radical treatment in the form of surgery or radiotherapy were suitable for a tissue-preserving approach to treatment. And that could involve active surveillance or selective treatment of a dominant or clinically significant lesion. And it was just interesting to see the degree to which these men were willing to go to in order to see whether they're eligible for these treatments so that they might preserve function. I think also this kind of duty of care that we have to constantly strive to make our treatments better tolerated for patients, less invasive, better tolerated, more easily done, is something that we as clinician scientists need to embrace. And the ultimate focal therapy, I suppose, will be at the cellular level, where we have an antibody that goes to the cell or cells in question and does the selective destruction at a cellular or microscopic or indeed molecular level. And this is just a process of trying to get to that place. And this has already been mentioned, and the beauty about a focal approach is that every individual is treated differently because they're diagnosed differently. So our response to the patient is based on the information that we get from the imaging, which we're going to hear about shortly. Our biopsy strategy responds to that, as indeed does our treatment. So no prostate is the same, and therefore no treatment will be the same. And we start to get to this approach of personalized care. This was published this morning. Some of you that were up early will have seen it. A lot of us have been chatting about it already. I think I might be the first person to present the PROTECT data in the world because America is still asleep and haven't woken up. There may be somebody in Japan or Korea that's already presented it. But this is going to have quite an impact, I think, on the way we practice. There hasn't been much time to digest the data, but suffice to say that there was very little benefit to be had from surgery or radiotherapy compared to active surveillance. And in an accompanying paper, it showed us that there is quite a lot of harm that is associated with both surgery and radiotherapy. There shouldn't be any particular surprise to us, but it's whether this data is going to change the landscape in some form, particularly in relation to a risk-stratified approach to care. And I think actually that it may do. There was the only significant increased rate of progression was seen in the active surveillance group, which we can see in this dotted line here. So the men that were assigned to active surveillance had an increased risk of overall progression and indeed metastasis. So there may be a role here for an intervention to try and treat those individuals who are at risk of progression, presumably with a higher risk disease, and try and mitigate that difference. Oops. And the other issue that the study pointed out is that about half the men, 44% of the men on active surveillance, remain free of requiring radical treatment or crossover to radical treatment. But that does mean that the majority, close to 2/3, were initially assigned to active surveillance but had to cross over to treatment. And obviously a lot of men wish to stay on a tissue-preserving strategy if they can, and therefore avoid the side effects of surgery. And again, I think here there is opportunity here to see if we can risk stratify with great precision up front and allocate a treatment that is well tolerated, that actually flattens this line or indeed decreases the upward trajectory. And I think here there's some role for focal therapy. The reason I brought my laptop up was just to quote the concluding words from Freddie Hamdi in the PROTECT trial, which you'll all be able to read. And he says, men with newly diagnosed localized prostate cancer need to consider the critical trade-off between the short and the long-term effects of radical treatments on urinary, bowel, and sexual function, and the higher risks of disease progression with active monitoring, as well as the effects of each of these options on quality of life. So I think that sets it up very nicely. If we could come up with a treatment that could reduce progression rates, reduce crossover rates, but was extremely well tolerated, we'd have a treatment that would probably serve the preferences of most men. And I think it's this transition from an era where the risk stratification occurred after removal of the prostate, because that was your first opportunity to identify all the lesions within it. You can see the dominant lesion there, but this man may have had his prostatectomy because the lesser lesion was randomly sampled in a prostate biopsy, to an era now where we can actually do an MRI and identify not only this man's small lesion, that apical lesion there, which proved to be a clinically significant lesion, but also to warn us that actually there's a much bigger tumor situated, just there, occupying most of the left peripheral zone. So we will not undertreat and we will not overtreat, or if we do, we will do so to a lesser degree. And I think it's just worth showing the degree to which the MRI might help drive that decision process. This is Panebianco from Rome. It's a 2-year-old study just showing the dominance of an MRI pathway in terms of detection. The detection rates were twice that seen in the traditional pathway. And remember, PROTECT didn't use 12-core biopsies, it used largely 6-core biopsies. So the risk stratification within PROTECT would have been very poor. But for our purposes here, it's just how MRI dominates the prediction model in terms of what's in the prostate. So if you were told that you were all clear and your MRI was clear, your residual rate of prostate cancer was very low, and if you did have prostate cancer, it was relatively low risk. If you were told you're all clear on truss biopsy and your MRI was positive, your risk of prostate cancer went to close to 90%. So in other words, the outcome of truss biopsy was almost random, and the true presence of clinically significant disease was dominated by the MRI. And also, I suppose, this issue of negative predictive value. So in her study, not all studies, but in her study, if your MRI was negative, and that's truly negative, you were at very, very low risk of having clinically significant disease. And this is the thing that has transformed our care, and Claire shortly is going to tell us a bit more about it. And I think this treatment is not in competition with surveillance or indeed whole gland therapy. This is a spectrum of care that it's our job to allocate efficiently and correctly. And I think in the middle, with these new strategies, we have something that might be called focal therapy or tissue-preserving therapy or lesional therapy that fits very nicely between the two. This is, can we start? Maybe I can start it. This is just a treatment taking place. Oh, it doesn't work. Let's go to the next slide then. It's been flipped. This is our story of how we very, very gently and safely approached this question. We weren't the first to do it. There were surgeons in fact, radiologists and surgeons in the US, largely in Florida, who were experimenting with tissue-preserving therapy long before we started. But the first study was the hemiablation study, where we went to great lengths to be as sure as we could that there was no disease on one side of the prostate and clinically significant disease on the other side of the prostate. This was done with MRI and 5mm template sampling. It took a long time to accrue 20 patients, as invariably there was 1mm of 3+3 on the contralateral side, and those patients were excluded. We did eventually recruit, and that paper was published. And I think the big discovery from that was that tissue preservation made a huge difference in terms of genitourinary outcome. You know the results. All men were continent, and nearly all men had erections sufficient for penetration with or without medication. So having developed our confidence with that, we came up with another study that would allow us to recruit men more quickly. In retrospect, this was probably overly ambitious in that it took our diagnostic strategies to a place that they weren't really capable of, and presumptuously what we attempted to do was to identify any disease within the prostate. So there was some bit of cancer there, and there was a bit of cancer there, and then we, of course, could treat up there and treat up there. So this was essentially a multi-lesional treatment. Men could have one treatment or indeed contralateral treatments. And again, that recruited very quickly. Men loved the study. The oncological outcomes weren't quite as good, largely because of the reduction in the margins that we were applying to these lesions. So there was greater opportunity for misses, both diagnostically and indeed therapeutically. Once we completed that study, and that was the Lancet Oncology study, we started to kind of understand that the notion of no disease was really a con. We were kidding ourselves that even in 5mm template biopsies, when we were declaring freedom of disease, we weren't actually declaring freedom of disease. We were declaring freedom of disease above a certain volume. So 5mm template sampling can exclude a 0.2 cc lesion with 95% certainty, but it can miss every time a 1mm lesion that's sitting between your sampling frame. And so it's then that we started to, I think, become a bit more sophisticated, and just like we do in active surveillance, draw a threshold in terms of disease severity above which we treat and below which we don't. In active surveillance, we do it at the patient level. In these studies, we did it at the prostate level. So we would identify clinically significant disease, dominant pattern 4 or secondary pattern 4 above a certain volume, and we would permit 3mm or less of Gleason 3+3 to exist because we couldn't reliably rule it in or rule it out. And therefore, if it was there or not there, it didn't matter from a detection perspective. And as you can imagine, that recruits very quickly because 80% of men fit into that, as most men have a dominant lesion accompanied by lesser lesions which can exist on the same side or other side of the prostate. And I suppose this is a trajectory and an experiment to see how far we can go. In other words, and in fact we were having a discussion earlier on with Fernando about what were we prepared to leave behind and indeed monitor, because our patients push us to try and increase the threshold for inclusion into these studies. And I suppose once we get to this phase where we have a clinically significant lesion and another clinically significant lesion, whether in the future there might be a role for adjuvant therapies, whether that be weight reduction, dietary change, a well-tolerated immunotherapy, for instance, to manage the background tissue, or indeed 30 or 40 gray of radiation as we do in the breast. So I think this is the kind of really interesting question for the future. Preserve your prostate, preserve your function, and come up with an adjuvant treatment that is well-tolerated but allows you to preserve tissue and function in a greater proportion of men. So in a sense, that's the story so far. And within this, there have been a number of technologies. And what's very interesting at the moment in working in this field is the extraordinary innovation in medical device companies coming up with technologies that are going to help us in the future, both direct the energy and indeed the type of energy that we direct at these lesions. And it's not only heat and ice and stuff. The radiotherapists are at it, and there are groups now doing focal therapy with brachytherapy, but also with HDR, and the discussions are starting with proton beam therapy and pencil beams, which can be directed and motion controlled against respiration. So I think we're going to see quite a lot of activity in this field, not all of it driven by the urological community. This is a story from start to finish, and the point of this, I think, is the degree to which we are dependent on imaging to deliver every component of this pathway. The modern response to an elevated PSA is an MRI. That's what I would have if I had a PSA of 6.7, and it was useful in this gentleman because he had an anteroseptal lesion high up there at 1 o'clock. That lesion looked very much like a cancer, positive on the gadolinium scan, positive on the ADC, positive on the long B, the B2000. Surprise, surprise, the biopsies that were targeted at the lesion were positive, but not only positive, they give us a great picture of the heterogeneity within the tumor because you're sampling multiple times. The non-targeted biopsies were negative. This is a typical story for targeted biopsies, as we'll illustrate and discover later on. The abundance of tissue. In a traditional biopsy strategy, you would be lucky if you'd hit this once. You probably wouldn't hit it if you didn't know where it was. Now we're presenting the pathologist not with 1 or 2 millimeters of cancer, but with 2 to 3 centimeters of cancer, which gives us enormous opportunity to do fancy tests on such a large amount of tissue. And I think that's a great opportunity for biodiscovery in the future. Everything's dominated by the imaging, as is the treatment. This chap had nanoknife. We're going to see one later on. All you have to do is get the needles around the lesion, and then the very high voltage electricity takes care of the rest. 4 needles, 6 treatments, which delivered over about 15 minutes, produces a nice lesion at 1 week, and you can see absence of perfusion in the area treated, but complete preservation of key structures. So everything else in the prostate is well perfused, including the urethra, neurovascular bundles, etc. That's 1 week. If we do one at 6 months, the PSAs come down from 6.7 to 1.7. I think if you presented this to a radiologist and hadn't told them the story, it would be reported as a normal prostate. So in other words, it's very difficult to see that this prostate had cancer before and indeed had that cancer treated. And again, just look at the degree to which the structures are preserved. We'll skip through that. So the functional outcomes of these treatments depend, I think, on the preservation of key structures. And on this coronal image that was done 1 week later, you can see that the sphincter mechanism looks completely intact, and the lesion that was created is nowhere near that. The bladder neck mechanism, apart from some midline necrosis, looks intact and I'm sure would be functional. Indeed, this man did have antegrade ejaculation after treatment, which he managed to have with good erections, largely, I think, because the neurovascular bundles and indeed most of the blood supply is indeed preserved. The outcomes that I've said have been reproduced time and time again now. Men expect to have 100% drip-free, pad-free continence. Men expect to have good erections afterwards, though you have to tell them that they will not be as good as before. And between 90 and 95% of men with good erections at baseline will have erections sufficient for penetration if you treat half the gland or less. About 30% of the patients who weren't using medication before will need medication afterwards. So we do eat into the reserve in terms of sexual function. Once you start treating men who are already on Viagra or Cialis, the outcome is much, much harder to predict. There's been some interesting analyses done by our andrology team who've taken our data from the 3 studies and recently published it, but showing remarkable preservation of sexual function in these 3 cohorts. The first cohort had good sexual function. We selected men with good erections at baseline. It was essentially a toxicity study, and subsequently we relaxed that. So this analysis includes a wide cohorts of individuals. Overall IEF, slight reduction after treatment as you'd expect, and then a return to baseline. As I've said before, you need to warn the men that if they aren't using medication prior, they need to use it afterwards, and a large number of these men will be put on Cialis 5 milligrams once a day post-treatment. We do have some new data. It hasn't been published yet, and this is until today, was the first randomized trial of active surveillance. It's now going to be the second trial of active surveillance, but this is against a focal treatment, and some of you were investigators in this, and this is the 2CAD study. But for our purposes, and I think the purposes of interpreting PROTECT, the data are interesting. This is the treatment, so in other words, the intervention in this study was a hemiablation of the prostate. Some men in the study were permitted to have both sides of the prostate treated sequentially if they either had or indeed developed bilateral disease. So it includes men who had a hemiablation, but also a small cohort of men that had a whole gland ablation that was achieved sequentially. The study was designed a long time ago. It's a very low-risk study, and so in terms of cancer risk, doesn't quite apply to our current situation, but nevertheless I think serves us well, particularly in relation to PROTECT. It does show that the progression rates were reduced significantly. Remember the slide from PROTECT. Active surveillance had higher progression rates than treatment. Here, if you were randomized to the intervention, you had lower progression rates, 28% versus 58% on sequential biopsies at 1 year and 2 years, as you can see here. Men that were allocated to 2CAD had a much lower risk of crossing over to radical therapy, 6% versus 30%. Remember, this is a 2-year study, not a 10-year study, 12-year study like PROTECT. And unlike PROTECT, men who were treated in this study had almost an identical functional outcome to those men that were observed. I haven't had time to show you the data from the accompanying study in the New England Journal of Medicine today, but it does show a very high level of toxicity associated with treatment. And with focal therapy, that appears to be absent when measured by IEF and also by the IPSS. And in terms of safety profile, I think this is where the data is really shouting out to us. This was a multi-center study, lots of lots of hospitals throughout Europe, both teaching and community. Very few of these centers had any experience in focal treatment or indeed putting needles into the prostate. There was a slight excess of moderate toxicity in the treatment group, as you'd expect, and that was dysuria, hematuria, retention. But really importantly, in terms of severe complications, the intervention group was almost identical to the active surveillance group, telling us, I think, quite emphatically that this treatment can be delivered extremely safely to a wide group of men across a large number of centers and countries throughout Europe. So we concluded, and the study hopefully will soon be published, that this was safe, well tolerated, desirable, very quick recruitment, amenable to quality control, and effective at reducing the rates of progression, conferring a negative biopsy status, and diminishing the need for radical therapy. And I think this fits very nicely now with the PROTECT, and will be very interesting once the discussion starts about how these two studies will work together. So in summary, I think we were forced to come to where we are today. I think the new diagnostics force us to make the question and indeed address the question. And many colleagues here are working very hard to deliver the question through well-designed and beautifully conducted studies. I think the future will be about risk stratification, but I think also the very exciting thing around the corner are the new technologies that are being developed precisely to allow us to meet the demands of the task, rather than asking us to use technologies of the past and reapplying them to different challenges. So with that, I'll conclude with one more slide, and this is about kind of prostate stewardship, is that maybe our new role, Protect, and the STIBA study, when it's published, will actually give us the confidence now, because Protect will give us that. Very, very few men died in that cohort. That actually the challenge is to preserve the prostate tissue when we can, either through not treating it or through treating it in an extremely selective way. Thank you very much.